Now call upon the next speaker, Dr. Sarkar, to speak on off pump, the current perspective. Thank you.
Good afternoon. This is supposed to be a kind of action replay of the presentation that we did in the IACTS and the EACTS joint CME in Kovalam. Now, those of us who, incorrigibly has been connected with coronary surgery over a period of last few years, has been wearing the medallion of off-pump surgery very proudly, and we still continue to wear it. But this entity of off-pump surgery has come up for some bashing, and to use this sort of literal analogy with the ancient non-violent sport called boxing. So that is why, a few boxes have launched on the face of off-pump work. And we seriously need to introspect what we are doing and what we will continue to do in the future. And hence, I titled my talk that off-pump CABG, the punches have landed. Now, this is a kind of boxing match, and the boxing match that a coronary surgeon is usually most used to is fighting the cardiologists. So myself included, a lot of cardiac surgeons have gone on having arguments with the cardiologists to decide that what was better, PCI and CABG. So the PCI versus CABG fight has been going on for a long time. But of late, the PCI versus CABG fight has been replaced by the on-pump versus off-pump fight. And what is really, really amusing is that these two fights are almost resembling one another because we are fighting exactly on the same terms. On terms like long-term results, the adverse cardiac events, graft patency, and things like this. Now, who is it who landed the strongest blow on off-pump CABG so far? Now, those of you who've got a few minutes to look up from your textbooks and do flip through the pages of the journals, would have read the article in circulation. This was not a paper. This was a review article written by Harold Lazar. Harold Lazar is a pretty influential adult surgeon from the Mass General. And Harold Lazar, in circulation of just the year gone by, 2013, wrote this special report. The title of the report was that should off-pump CABG be abandoned? And this followed with a big question mark. So as if Harold Lazar's pronouncement that off-pump CABG should be abandoned, this was followed by another very authoritative writing. And this very authoritative article came from, some of you would perhaps know that what the Cochrane collaboration is about. Have any of you heard about the Cochrane collaboration? If you have not, then go back to the internet, type Cochrane collaboration. Cochrane collaboration is a little bit like the Wikipedia of medicine. So it is a very influential UK-based review board. And every year they review various issues, starting from pharmacology to therapeutic to basic science. And they invite specialists who will review respective areas and come back with very powerful kind of pronouncements on each subject. So Cochrane collaboration in the year 2013 did a review of off-pump CABGs, and this was what we call the Cochrane conclusion. So what the Cochrane conclusion actually said, this is an extract, and obviously not the whole thing, that our systemic review did not demonstrate any significant benefit of off-pump. In contrast, we observed better long-term survival in the group of patients undergoing on-pump CABG. And somewhere later on in the report, they conclude that on-pump CABG should continue as the standard surgical treatment. Now, the Cochrane group went as far as this to make this recommendation based on 86 trials with 10,716 patients. So this is not something they just got out of the wrong side of the bed and said one morning. So in summary, what has been the argument so far? What has been the contention so far? The argument so far between this India-Pakistan war between off-pump and on-pump has been, number one, that off-pump CABG is not better in the short term. Point two, that off-pump results in incomplete revascularization, which is lesser number of grafts. If somebody needs 4 grafts, you are doing 3. If somebody needs 3, you are doing 2, stuff like that. Point 3, inferior long-term results in terms of MACE. I'm sure you know what MACE is by this time. It means major adverse cardiac events and inferior long-term survival. And obviously, the principal critique of off-pump technique over many, many years has been the problem associated with a steep learning curve. It is not a very easy operation to learn, especially for the beginners. Now, when we discuss anything, we have to be generally aware that what is the source of data? What, by and large, is the source of data that we have looked through and we have browsed through over a period of time? Now, the types of data sources we look at are, number one, the most popular and the most easy sources of data has been the retrospective series. Retrospective studies, retrospective series, I'm sure you know what retrospective studies means. Like suddenly one day we sit down and try to see how the last 100, the last 200, the last 500 CABGs have done. I'm not saying we are fabricating data, but it is basically analyzing and publishing data of something we have done in the past. So we did not really construct a study before. Something was done in the past and analyzed later. That is called a retrospective series. Second is what is called propensity matched. Now, retrospective series, honestly, is not very seriously regarded in peer group literature. So if you and I want to look at 500 patients of on-pump and 500 patients of off-pump and make a serious article out of it, then you have to refine it statistically. And that statistical refinement is called propensity matching. It is like matching characteristics: age, ejection fraction, unstable angina, diabetics, etc., etc. But by far the most powerful data comes from the RCTs. Now, what does RCT stand for? RCT stands for Randomized Controlled Trial. So from the very beginning, you and I decide that, look, we want to analyze the results of the next 500 CABGs we are going to do, so many on-pump and so many off-pump. So the thinking is done before. The parameters of comparison is decided from before, and we do not choose according to our wish. That you walk into theater and say this is on pump, he walks in and says this is off pump. It doesn't happen like that. It is all blinded. You pick up envelopes. These days it can be done over the internet. So it is called a randomized controlled trial. So in very simple terms, what a randomized controlled trial does is it removes the element of clinical bias. And last but not the least is what you call meta-analysis. What is meta-analysis? You look at anything, whatever be your subject, from a haircut to a brain transplant. You've got 1,000 randomized controlled trials on that. So if you are a very brilliant statistician, you will sit down with data from all the 1,000 trials and analyze them once again. A little bit like what the Cochrane collaboration did. They meta-analyzed 86 trials. So when you group lots of trials together and put it to fresh statistical processing, that is what is called a meta-analysis. Now, coming back to our topic and subject of today, we need to be aware of the current literature. What is floating around in the atmosphere vis-a-vis the current literature? So we, first of all, will look at some of the most powerful retrospective data that we have with us today. Perhaps the most voluminous, the most powerful retrospective data comes from the works of Rux and Hanan. Those of you who follow coronary artery data would know of Hanan's work, which was published in the late 1900s in his comparison of PCI and CABG. So Rux and Hanan looked at the New York State Registry data. I will discuss that data in the next slide. Then you had Sabic from the Cleveland Clinic. Now, Cleveland Clinic is very famous for literally not doing any off-pump at all. But Joseph Sabic is one of the fewest surgeons in Cleveland who did it. And he looked at his own 812 patients, and Michael Mack had a similar data, which was like a meta-analysis. Now, just concentrate on this very important piece of analysis, and this very important piece of work is looking at the New York State Registry data, which is a comparison of short and long-term outcomes after off-pump and on-pump coronary artery surgery. And a few things which are important over here basically is, I'll again summarize this for you later, that this series was really looking at something like 9,000 off-pumps and almost 50,000 on-pump patients. They were tracked for 3 years. And this is the summary of the on-pump and the off-pump retrospective data of the New York State Registry. So they looked at 3 years data, 9,000 plus off-pump, off-pump, and 59,000 on-pump. And what were the main findings? Mortality in the course 3-year outcome, mortality was almost closely matched. Stroke rate, a little bit expected, was slightly higher in the on-pump group. Bleeding was slightly higher in the on-pump group. But what was remarkably significant was the requirement for repeat revascularization. Now, what does repeat revascularization mean? Repeat revascularization means the necessity for a second procedure. Whether you need a second PCI or a second CABG or whatever, if you need a second procedure, it is repeat revascularization. So repeat revascularization higher in the off-pump group. And when you do a risk-adjusted 3-year survival analysis, so the risk-adjusted 3-year survival analysis was slightly, not remarkably, but slightly in favor of the on-pump group. Now, as I said, you had the New York State Registry, the Sabic's data, Michael Mack's data. So if you put all these data together and try to have a composite picture in your mind, that what does the retrospective data tell us? This is the summary. And that summary tells us that off-pump CABG is slightly superior in terms of bleeding, atrial fibrillation, hospital stay, enzyme release, neurocognitive differences, but it is inferior to on-pump CABG, definitely in terms of number of grafts performed. So it is not an individual's comment, it is a comment which is made by extrapolating data for thousands of patients. What about stroke rate? Now, stroke rate in CABG is a very important event. You cannot take post-coronary strokes lightly. Those of you who have had the chance of studying the syntax trial seriously, from the year 1, now syntax trial data is closed, the 5-year results have been analyzed, and from year 1 right up to year 5, if there has been one spot of weakness in CABG vis-a-vis angioplasty, that has been the highest stroke rate. So stroke in CABG is a very important morbidity. So now when we look at stroke vis-a-vis off-pump and on-pump, the current scenario is, as we saw in the New York registry, that off-pump has a slightly lower stroke rate at 1.6%. Now, one very interesting piece of work was published by this gentleman from US called Sharoni. And Sharoni, in Circulation 2003, had a very interesting work. It's a very daring work. I don't know how he managed to publish it. And this is, he published more than 100 odd patients who had a CABG with plaques in the aorta. So he is studying people with already diseased aortas. And in this series, he has found the stroke rate of 2.4 in the off pump and almost 5% in the on pump. And what about the mortality? The mortality difference is huge. The on-pump group had a mortality of about 11.4%. So, vis-a-vis the stroke rate and the mortality from stroke rate, there seems to be a difference. And off-pump can feel a little bit happy that you were causing less stroke-related mortality and morbidity vis-a-vis off-pump work. But the problem really, the whole subject gets a little bit deeper as you come to the year 2010. Now, why was the year 2010 important? The year 2010 was important because the results of the Ruby trial, the Ruby trial was a veterans hospital aligned trial with 2,000 odd patients, which was a randomized trial, which looked at off-pump versus on-pump in roughly 1,000 patients in each group. Now, the results of Ruby trial caused a lot of turbulence, and Ruby trial data was published in 2 installments. One installment was the results of the trial overall, and the second installment was vis-a-vis the coronary graft patency and repeat revascularization. Now, this is the summary. This one slide is the summary of the coronary status post-Ruby trial. What does that show us? It shows us something which is a little bit disturbing. And why is this disturbing? Because if you consider the off-pump group, only 50% patients had what you would say complete revascularization. This is something to be worried about. But in the on-pump group, the complete revascularization is not very high either. It is only 63.9%. So what do we mean by complete revascularization? It means that before you walk into the operating theater, 2 people has got to score the angiogram and write what is the optimum number of grafts used. And at the end of the operation, you will have to say that, how many grafts you've done. So actually the percentage, it is not fair to describe it as a percentage, because if you set out to do 4 grafts and you did 3, then your index of revascularization will be only 0.75 or 75%. So it is really not possible to have a 90% revascularization unless you were planning to do 10 grafts and you did 9. So it is important to understand the mathematics of complete revascularization. The mathematics is that from 100%, it is very easy to slip to 75%. From 75%, very easily you will slip to 50%. So that is why the cardiologists got very excited about this data. And I actually wrote a review and I explained it to them that, look, if you set out to do 4 grafts and you did 2, it's not that bad. It's better than you doing an angioplasty on a single vessel. But that in our revascularization index would mean 50%. So it is like a point of self-criticism. But this is again very serious figure. Even if you look at the patency of internal mammary and other arterial grafts, 85% in off-pump and 90% in the on-pump. Similarly, graft patency in the venous grafts are also less. But Ruby trial was definitely flawed over here. Not flawed, this was a point of weakness. They had a 12% conversion rates, and people all over the world started jumping up and down and said, look, they had a lot of trainees, a lot of young people operating. I am all for young people operating because I always believe young people operate far better than older people. But over here, there was a lot of criticism saying that they had a 12% conversion rate, which means they had an inexperienced group of surgeons, so on and so forth. So after the turbulence of Ruby trial, so Ruby trial was like the first kind of provocation where people realized that all was not well, that you could not be complacent about the off-pump data anymore. Now actually, when we were looking at the results of the Ruby trial, Then we dug up a paper that was done about 5 years before. It was a very small study. It only had 50 patients on either side. It was done by a very hard-working girl from the Brompton Hospital. I had a chance to speak to her. So Natasha Khan from the Brompton Hospital, along with John Pepper, etc., had done this study, a randomized controlled study, where she looked specifically on the area of graft patency. This is actually now considered after, but in the time scale, this was done before Ruby trial and published in the New England Journal of Medicine. Now, she looked at 50 on-pump cases and 54 off-pump cases. And this is the finding from Natasha Khan's series about off-pump into on-pump, where this is dividing patency into territories: LAD, circumflex, right, and this is the overall area. So in other words, whether you analyze it territory by territory, or if you look at the overall graft patency rates, without a doubt, cases which were done on pump did have a higher graft patency. And we just need to clarify that when in so-called American and British literature we talk about on-pump, we generally do not talk about on-pump beating heart, because they rarely do on-pump beating heart. If they do on-pump, it is customary cardioplegia, antegrade, retrograde, etc., the whole works. Now, this led to some discussion, which we will discuss sometime later on, not in this afternoon, about graft verification, that should off-pump surgery have a rigorous graft verification like transit time. I'm trying to start, hopefully in a month or two, we shall start a program where every off-pump surgery is going to have a Medistim transit time graft patency measured. There was a technology called Novadax SPY, and later on this year, I think a paper which is co-authored by myself and my friend Pradeep will figure in Innovations this year, where we have looked at our first series of early graft angiography. Right now, I'm a great believer. I'm very happy to have people a re-angiography within 2 hours of surgery. If there is any changes in the ECG, if there is any clinically, something is wrong. Because I have not got transit time yet, I'm trying to get it. Hopefully, we're going to have it very shortly. Now, surgeons from all over the world got together and said, look, we are a little bit unhappy. We are a little bit concerned about what's happening. And a couple of big-time randomized trials were thought about, and one of them was called the coronary trial. The coronary trial had, I think, 3 Indian participants, and I've picked up Anil Jain from Gujarat, Balram Iron from All India Institute, and probably Coimbatore, Chandrasekhar was one of the participants of Andre Lami's coronary trial. So you had 3 Indian centers contributing to the coronary trial, which had about 2,100 patients in it. Now, in summary, this is Andre Lamy, who was the chief investigator of the trial, 4,752 patients. And in other words, what the results of the coronary trial showed was, in terms of short-term advantage, in the average patient, off-pump surgery was not markedly superior. But what was very confusing was the recommendation of this gentleman at the end of the trial. At the end of the coronary trial, he gave a very strange recommendation, which at least I have been very critical of. He said that since in the low-risk group you have no difference, in the average low-risk patients, you should be doing them on pump. And in the high-risk patients, you should be preferably doing them off pump, which I found very confusing. Because if somebody did not do enough patients, low-risk patients off pump, how on earth was the surgeon going to have enough confidence to do a bad coronary 25% EF off pump? I do not know. So even very educated, very expensive trials can come up with very absurd recommendations as this one. The Germans had undertaken a trial which was called the GOPCAP trial, and the German trial was important, not only because it was on-pump versus off-pump, but because it looked at patients who were more than 75 years of age. So they were dealing with an elderly population, people above 75 years of age, randomized into on-pump and off-pump. And at the end of the COPCAP or the German trial, once again, there wasn't a huge difference in the two groups. So they were almost similar to one another. And one of the very few hard-time believers of off-pump work in the United States have been John Puskas of Washington Emory. And John Puskas had his own randomized series of 200-odd patients on pump and off pump, and basically there was no difference between the two groups. So people who were serious about analyzing and examining this data probably said that understand the politics of it, that what were we upset about at this stage? What we were upset about at this stage was that doing off-pump work, we almost took it for granted that across the average patients, your outcome is going to be better. And across the average patient, across the so-called low-risk group, there was nothing in literature that was showing us that off-pump was remarkably superior to on-pump. It did not. So some of us, and, like our colony of coronary enthusiasts, we have probably a couple of leaders, and one of these leaders is David Taggart. And David Taggart wrote a couple of reviews at the end of it. He did have a statistical point, though I do not agree with him for everything. He did have a statistical point. His point was that in order to see differences in the average patients, you need larger numbers. That these trials of 4,000, 2,000, 3,000 are not strong enough. Numerically, they are not big enough to show the statistical differences. He may have a point in it, he may not. But then, where on earth today are you going to get 20,000 patients in this trial from? I'll come to this paradox in a minute. Very briefly, we will deal with off-pump and the high-risk patients. Now, there are many methodologies of defining what constitutes a high-risk patient. I was examining somewhere a few months ago, and I asked somebody, what is your definition of high-risk patients? I got very, very interesting answers. But those of you who appear for exams can look up this paper because this has a very interesting concept. Because Society of Thoracic Surgeons, mind you, STS database tries to avoid following your Euroscore. So they are a bit politically different. They don't follow Euroscore the way we do. So those of you who know what the STS database is about, please know what PROM is about. And PROM is the definition of predicted risk of mortality. Before you get to do any operation, there is something called a PROM figure, or a predicted risk of mortality. And if you analyze these figures, on a predicted risk of mortality, so this is like your higher risk group, this is like your lower risk group. So in the people with CABG who were done on cardiopulmonary bypass in the high risk group, obviously in the higher predicted risk of mortality, the mortality rates were slightly higher. So there was some study which at the end of the day showed that off-pump CABG was superior in the high-risk group. Then there were a lot of meta-analysis coming out. There was a chap called Affialo who looked at 9,000 patients. And this is a meta-analysis which is quoted very often in literature from Jarrell, which actually makes a very provoking statement. It says that off-pump CABG increases mortality risk by 1.37. Those of you who listen to Ben Bridgewater in ISETS, Ben Bridgewater has actually statistically proven that the operation of bilateral mammary in itself is a higher operative mortality risk factor. A lot of people have shouted at him for that, but there you have statistics for you. He has it in the British database. Now we in India, we do not only have statistics to fight with, we have the daily fiscal realities, the finances to struggle through every day. And we are aware of the fact that it gives us at least a 30% cost advantage. There is a significantly lower risk of production, and the off-pump technique makes us more kind of cost competitive. And cost competition, mind you, is not something very peculiar to India alone. Why not? The same reason we prefer off-pump over on-pump in terms of cost is exactly the same reason why somebody in the United States prefers PCI over CABG. Because in the United States, PCI is less expensive than CABG. So, whenever you talk about health economics, the fact that we are cost conscious, you need not be very guilty about that, because every society is cost conscious. The National Health Service in the United Kingdom makes a recommendation that in double vessel disease, go ahead and do more PCIs than CABGs, because their PCI is less expensive than having a CABG done. So everybody is cost conscious, and we also have a right to be cost conscious in our own way. What really worries me in general, and a lot of other people who are involved in coronary work and off-pump work at the moment, is that whenever you end a discussion and say that, look, we are a little bit worried about the status of off-pump CABG at the moment, there is a little bit of uncertainty in the air, I'm sure somebody will put the hand up and say, okay, friend, we need more data. But I'm very worried. Where is the data going to come from? 15% off-pump CABG in Europe. 19% is the highest off-pump rate in United States. So I'm really not sure where the data in the world of the next 10,000 patients is going to come from. Is really worrying. The data in the world is drying up. And to use an old aphorism, India is asleep and the West is abandoning. The anecdotal Indian experiences, big-time Indian surgeons going about and say, I've done 10,000 CABGs in my sleep, all off-pump, 110% mortality, minus 0.5% conversion. That kind of data is not believed by anybody anymore. And this brings us to a very fixed issues. Some of the people in the last ICTA started having, nausea and vomiting after this slide was shown. Because we are under the belief that in India, people believe that, we have 90% off-pump rates, 80%, and things like that. So I did my own homework, and I'm not the only one. I had asked 3 people to do the data gathering, so we acted as a national database in disguise. So last year, in the year 2013, about 119,000 something coronaries were done. So in India, we did roughly 120,000 coronaries, 30,000 valves, and 30,000 congenitals, which makes the entire operative output in India around 180,000, 1.8 million cases we had done in a year. So what is the current off-pump CABG rate in India for the 120,000 odd CABGs done? Contrary to a lot of what we believe, today it stands at something like 49%. So the off-pump CABG rate in India in 2013 is a little below 50%. And there are many, many factors which are responsible for this. It is not just your familiarity with the process. A lot of it has got to do with the learning curve, and a lot of it has got to do with training. So, it is not time for us to behave like, sort of maniacs and single-headed vision regarding off-pump work. Yes, I still remain to be a great believer in off-pump work and do it myself. But let us go home with the message that we need a lot, or 3 people out who are surveying about 50 6-year candidates all over India. And so far, the results are dismal. The results are that most of these units are using these boys and girls like cheap labor. Their surgical exposure is down to absolutely vestigial levels. And hopefully, before my term in ICATS is up, I'm going to ask for a kind of monitoring committee because if the monitoring and the feedback reports are not adequate from the peer group association, I do not think the 6-year program should be given to that center. We are doing far more harm than good. So training today, of which this off-pump data, why is it declining 10% year on year, is an example of the very shabby level of training as it exists today. And the last is the problem of data. Where on earth are we going to get data from? In India, this data that we have shown you is industrial intelligence data, is not the data we surgeons have gathered amongst ourselves. And it is a mission. We are definitely trying to put a mechanism in place whereby by next year, quarter by quarter, some data from the national database is going to come up. So friends, in our lifetimes, you have known of an elegant operation called the closed mitral valvotomy. Very cheap, very Indian, very effective. And we do not want, in an international scale, these two operations of an off-pump CABG and a closed mitral valvotomy in the world scale to resemble one another. So we have been stupid enough before. We have done it once before. Hopefully, we will not repeat the same mistake again. So what else could be the ending rather than to say, wake up? Thank you.
I just want to ask you one thing, that of the on-pump surgery, when you are saying on-pump surgery, what's the rough percentage of cases on-pump beating heart and on-pump
Very. On-pump beating heart in Europe is not done at all. And the very few, the percentages will be very small number, less than 1 to 3%. It's only for arrhythmic work. So there are no elective cases, and when you look at that RCT data, mind you, most RCT data is analyzed on intention to treat. So if I started off this case as an off-pump, I had a problem and had to convert it. At the end of the day, the result will be shown as an off-pump data. That result will not be shown as an on-pump data. But I think I did mention it somewhere that both the Americans, Europeans, Australians, Japanese, whoever I have spoken to, they are not really very keen on pump beating. So if they do on pump, they do it in the pleached heart, antegrade, retrograde, etc., etc.
So this on-pump beating is a separate identity itself in India.
I know it is true, Nanda, I know it is very true. Even I have tried to kind of discuss it or argue it. It is very true, and all of us, we do it time and again. But I still find it, honestly, it's a bit baffling to me that why people have stayed away from it. And there were, because the fact that we do not read, that we are protected by our ignorance, which is good. Because if you do look up, again, literature is a dangerous instrument, that the Cambridge group, the Oxford, there is one group from Mass General who wrote a couple of very nasty papers saying that if you do on-pump beating, you get a lot of subendocardial ischemia, a lot of blood diversion. There are a couple of actually MRI pictures, and some of these MRI pictures are a bit frightening. So probably, we managed to avoid global ischemia. But in trying to avoid global ischemia, what else has happened is a question. But I must say, graft patency is something. If something I'm worried about now, I think number of grafts, complete revascularization, we have to be very serious about. Yes. 3 years. Yes, it was. Either way it was poor, Either way it was poor because there are about 20 papers which followed Ruby trial. So they dissected the hospitals who participated. There were surgeons who were operating who had done less than 50 coronaries themselves. So all those things were there. Yes, true. Yes. But but again, one thing that this is an interesting thing. There is a couple of other publications recently. See, if you analyze data, say from 1990 onwards, I really think you will struggle to show Lima patency of that 92% at 10, simply because you are operating on worse LEDs. Those LEDs, which had 95% patency at 15 years, those were different LEDs. Those LEDs are lost in transit now. Again, you go back to the Indian data 2013, 120,000 odd CABGs, 260,000 PCIs. So in India, at least we have already gone over. You're lucky. We are 2:1. Spain is running at 5:1. UK is running as 3.7:1. US is somewhere around 3:1. So even at 2 point something is to 1, it's not that bad.
What happens is that if we are doing a Lima anastomosis in a beating when the artery is anteriorly based, everything seems to be fine. Why there is this analysis of rep patency between off-pump and on-pump? How do you explain it?
Well, it's, Amarnath, it will be difficult to tell you why it happened. But the fact is, where I think the whole thing gets criticized is in the reproducibility of it. And honestly, there are papers and there are events. There are actually a lot of conditions in which people were kind of pressurized and forced to do off-pump work and so on and so forth, and they were intentionally avoiding grafting lateral wall vessels. People tell me of a certain center, which is not too far away from here, where apparently not a single lateral wall vessel has been grafted in years. Yeah. There is.
Now people are doing minimally invasive surgery, and there also we have the same problem.
Graft patency is horrible.
That's we know.
Graft.
So you have any data on minimal invasive?
Well, I'll tell you,
What is the present status of minimal invasive?
not too good. I mean, not too good. Because minimally invasive basically struggles with the access. Minimally invasive platform is difficult whenever you combine left vessels with right vessels. Then instead of doing, 1 4-inch incisions, you do 5 2-inch incisions. So actually your length of incision is more. So whenever you combine left with right, that is a problem. And honestly, you see, because in order to avoid the patency problems with minimally invasive, again with lateral wall vessel, you have this fashion which is very difficult for us, which is the hybrid revascularization. You do the LED diagonal, ramus, the easy ones, and have all the OM1, OM2, PDCX, angioplasty. I think, that is escapism. You should not be doing it.
Explain for those minimally invasive poor access, but when you're doing a full steroid,
I access.
vessel in front of
Again, there are...
in a fairly controlled conditions now we are doing with a proper octopus. Learning curve is also emerged over the years. People have become good. Still there is
You really think octopus that has been boiled 100 times is a proper octopus? Proper for us, yes.
this difference persists. It is a very tough.
It is. But this is showing up. This is showing up, and again, probably if we take the ball in our court, if we can, amongst 3-4 major cardiac centers, coronary centers in our country, if we can have a prospective, forget about 3-year survival, forget about 10-year survival, I think this will be a good project to think about. Look at 50-50 odd cases, and let us take a project where we angiogram our own patients and see how we do.
One thing regarding the stroke thing, off-pump, on-pump, most of the data would show that off-pump does better as far as stroke rate is concerned, and then thereby advocating even higher risk patients in elderly patients. But one thing that comes with a caveat that the off-pump in the form where you put the Lima to LED, put the side fighter on with infinity, and
you lose the advantage.
You just lose the whole thing.
Without a doubt.
That is something we all have to remember. remember that, when we advocate it for a higher risk elderly patient, and then again we are putting a sort of a sidebite with impunity and putting treatments on top of it, it loses the whole logic of particular emboli, stroke risk, everything. Because intuitively it would be more damaging compared to putting a single cross clamp on putting those.
The moment you have touched the ascending aorta, you have lost 1% of stroke rate advantage.
That's why
So,
in one of those IECTS, Dr. Bhattacharya put it that this way, that why not for early 70s patients, instead of doing a non-touch aorta technique using bilateral grafts.
There is some idea, yes.
Main vision behind this.
But there is a built-in contradiction in a lot of things we say. Now, if you look at this kind of like answering what is an ideal valve. You say what is an ideal coronary operation. The ideal coronary operation in a high-risk patient, your typical high-risk patient will have a low EF, a high creatinine, slightly elderly, your typical high-risk patient with a biggish heart. So in that substrate, your ideal operation is going to be an aortic no-touch, off-pump, with bilateral pedicles, which there is nothing wrong with it. There is nothing wrong in thinking about that operation. But the problem is having enough people experienced enough to reproduce it.
And again, doing them routinely in a low-risk situation to be able to do it.
That is why I found that
doing routinely bilateral anomalies on normal-sized hearts in younger patients, and they're flying off. Suddenly doing it in a 75-year-old obese, borderline creatinine, taking
it won't happen. That is what I really took. I've actually, wrote a letter to the editor saying that this recommendation is funny. This is not going to work. So, but probably what we can start off with is a few of us can sit down and think together, and have a small cohort of have about say anything between, because to graft, to prove a reasonable graft patency, not to prove, but to look at it. I think, like if you look at the Washington series, 100 patients, I think in this city we can gather it in 10 days and start off in the trial work. That is not much problem. We should do it because Avinath's question is very valid. Even I thought about it. That why should there be such a major difference? But again, another observation is, by word of mouth, when I spoke to a lot of young surgeons, a lot of trainees, all over the country, you see, this is perhaps one thing we do not see in and around Calcutta or Eastern India as much. We do not see a lot of centers coming up around the city. But centers which are coming up, in a lot of centers in the second order cities, the smaller towns and districts, and younger people going to set up those centers, they are, about 90% of them, to be on the factor of safety, they do their coronaries on pump. I have nothing to criticize them for. I'm just saying this is the phenomenon. And region-wise, I think if you draw a line kind of probably south of Mumbai, I think off-pump rates are not higher than 25%. So the entire south of the country, the off-pump rates are low. I think somehow the urban centers, it's a bit higher. And second-order towns and all, the newer people who are coming out of it. So I think, let's think about it, that we get together, and work out a small series to look at. Because these graft issues are very important. So if we think we are good at it, let's prove it. That's the question. Thanks.